Okay, take it away.
Um, Liz, if I may just introduce our two special speakers from Yukon,
Please do.
just a few minutes to introduce everybody to our two speakers. We're very fortunate to have both of them here today. Our first presenter is Dr. Alex Poole, who is a rural and remote multidisciplinary general surgeon. He's worked in general surgery up in the Yukon for about 20 years. He is very interested in mountain medicine and frostbite in particular, and has lived and worked in the Yukon, British Columbia, and Iceland. He has a mission to modernize Canadian frostbite care since 2015 and has been quite involved with publications on this topic. Our second presenter is Josianne Gauthier, who is a clinical pharmacist at Whitehorse General Hospital since 2010. She was instrumental in development and implementation of their frostbite protocol and has developed a passion for frostbite research since. She's contributed in recent publication of frostbite and presented at both local and international conferences on this topic. So we are very fortunate to have these two experts with us today to present on this topic. All right, without further ado, Dr. Alex Poole and Josianne Gauthier, thank you.
Well, thank you very much for having us. I'm going to try and share my screen here and then launch PowerPoint because that seems to be the better way of doing it for me. Now, can you see my screen?
Yeah.
Good. Let's get this center. Okay, it's my first slide up there.
Yes, it is.
Awesome. Thank you very much for having us. I'd like to acknowledge that Whitehorse is on the traditional territory of the Kwanlin First Nation and the Tan-Quechan Council. So we, not surprisingly, it's cold in the Yukon and we see frostbite. Back in the early 2010s, we started being more aggressive with our frostbite treatment. Partially, we recognized that we weren't necessarily doing anything different than anybody else, which was essentially waiting for the patients to thaw out and then deciding ultimately if they needed amputations or not. So we started a process to try and get better at that, seeing if there were more modern treatments that we could do. What we're going to talk about today is the outcome of that work that we've done. Not surprisingly, we get both people who are out in the cold expectedly and unexpectedly in Whitehorse. This picture is of a famous race that we have in the Yukon Arctic Ultra, that we get a lot of foreign athletes that come try to do this endurance event intentionally in February when it's the coldest possible, and they're self-supported and they try and bike or ski or some walk or run up to 500 to 700 kilometers from Whitehorse to Dawson City. Not surprisingly, some of our frostbite patients come from this group. So I'd like to make my declarations. I have no conflicts of interest, no financial disclosures to any of the medication that we'll talk about today. We do have a grant from the Northern Ontario School of Medicine for some of our research work. All of the photos that I'll be using today are photos that I've taken of my patients who have given me the permission to use them for publications and for teaching purposes. So first, I'm going to talk a little bit about the pre-hospital and hospital care and how you decide if someone has frostbite. We'll talk in particular about grading frostbite, which is different than the degree of frostbite that some people may use, and we'll talk about how that influences our decisions with respect to prognosis, which ultimately will influence how we treat these patients. And to really get into both of those, we'll have to understand the pathophysiological rationale for the treatments that we do for frostbite. So this is a typical case that we would get with our adventure athletes. So in Whitehorse, we found with our data that we have a slightly disproportional number of athletes or adventure people who are outside doing things in the cold, as opposed to people that just had an accident. So these people are intentionally out in the cold, didn't necessarily get stuck, which will speak to prevention. And this is the first case that we did with our protocol. And this was a Polish athlete who had planned to run 700 kilometers from Watson to Dawson City. He was actually leading the race at the time. And what we find with a lot of these athletes is some of them come from Europe, they've been in the Alps, they know what -20 or -25 degrees Celsius is, but they've never experienced -40. And those of you who have, you recognize that the cold never really plateaus. And as it gets colder, it gets worse. And while he was prepared for the cold, he wasn't prepared for that degree of cold and ran into trouble. So I'm going to try and discuss the natural history of frostbite, and hopefully at the end of this talk, you'll understand that you'll look at this picture on the right of his hands and be able to identify that this is a grade 3 frostbite on a scale of 1 to 4, and that the natural history of this is pretty significant for his risk of amputation. Historically, this is what we did, and this is what we wanted to do better. We would have someone with, on the left, which is a grade 4 frostbite, and we would ultimately warm them up and wait and see what happened and deal with amputations as we had. And you can see that this patient has already lost one toe and potentially is on the way to losing another one. And so our question was, could we do better than this? Is there something else we could do? So what we did is we looked at all of our data, we did a literature review, we contacted what experts we could find in the world, and our goal was to get people like this young man with fairly significant frostbite in this picture, and could we prevent amputations or at least minimize amputations and give them more function afterwards? So that began our journey to a frostbite protocol, and a lot of the work that we've done is what we'll discuss today. Josianne, in particular, is going to talk about the pharmacological interventions that we do. So first of all, who gets frostbite? Not surprisingly, it's people in the north, people in cold areas. There are large urban centers in Canada which get a significant amount of frostbite. In particular, Edmonton, Calgary, and Winnipeg are big metropolitan areas that get fairly cold temperatures. There's good epidemiological data out of Finland that shows that if you at any point get -15 degrees Celsius in your city, when you look at your environmental data, you're probably an area that people are at risk of getting frostbite. And our data is similar to this, the US burn registry, it's predominantly male. And we get 3 to 4 really significant frostbite cases a year in Whitehorse. We've recently analyzed the Ontario data. We have a paper pending publication, hopefully, on that. And what we did find as well is that even areas that don't normally get cold, if you look at their data, you'll find frostbite cases when they have just a couple of very cold days. So if you're in Southern Ontario and you've never seen temperatures of -20 and all of a sudden it's -20, not surprisingly, people are unprepared and are at risk of getting frostbite. Whereas in a place like Whitehorse, when it's -20, most people are prepared and used to it. So we tend to see our frostbites often when it's much colder than that. So this speaks to prevention. So this is the Yukon Quest, which is a professional dog sled race that is similar, goes over a similar distance to what we saw in the running race. And these are athletes that live and train in that environment and are prepared. And so you can see that this musher is wearing appropriate clothing for this -35 day when I took this picture at the start of the race. And while we do occasionally see frostbite in the professional dog sled athletes, we don't see that much, and it usually is not to a significant degree. So this is -35 degrees Celsius on this day. And the very next day, these are our adventure athletes. They go out and they take advantage of that packed course that the mushers have made. And you can see that these athletes are not wearing the same level of clothing and the same level of prevention as the mushers. And they are wearing, some of them, they look like glorified running shoes. So I do joke that these people are a perfect storm for a frostbite researcher. It's -40 degrees and we get a bunch of spandex-clad Europeans who come and want to run 700 kilometers. So not surprisingly, these are some of our frostbite patients. Our study is no longer completely controlled, though I do give them talks before their race now so that they at least recognize when they're in trouble. So how do you know you're in trouble? So frostbite injuries tend to go through 3 phases. There's the pre-freeze phase where you're starting to get cold, you're at risk of frostbite, and then you actually get the freeze phase, And then we'll talk about most of our therapeutic interventions are during this thaw phase or the reperfusion phase. So what happens if you're out in the cold and your car's broken down, you've taken your gloves off to start working your cell phone? So what data seems to show when we look at physiological testing is that at some point you start to get pain in your extremities. And what that pain is telling you is that the surface temperature of your fingers or your toes is probably down to around 15 degrees Celsius, normal being somewhere in the low 30s. The next step is that you get numbness. Now, a lot of people get some relief at this point because the pain is gone. But the numbness occurs somewhere around 7 degrees Celsius, which is probably when your peripheral nerves don't function well, and that's why you're numb. The really concerning thing is that that is your last warning sign. There's nothing that tells you that your numbness, which you're at this point not frozen, has progressed into frostbite, where your surface temperature is around 0 degrees Celsius and you're at risk of getting significant damage to your tissues. So obviously, if you're getting numbness, you need to do something, whether that's change the layer of clothing that you're wearing or get out of that environment. One thing that does occur that gets a lot of discussion is this cold-induced vasodilation. So when you are getting exposed to the cold, you do intermittently, temporarily get vasodilation of your peripheries transiently. So you potentially open up increased blood flow to your digits, preventing them from getting extremely cold. But this will fatigue and it certainly won't last forever. It's still an area of interest to try and see if there are some people that are more or are less prone to getting frostbite or more adaptable to the cold, but this is certainly not a permanent thing, and this is not going to prevent you from getting frostbite indefinitely. There are attempts to develop indices, see if you can test somebody in the lab beforehand to know what their risk of frostbite once they get an exposure, and this is certainly of interest to people who have to work in the cold or the military who has to deploy in the cold, and they want to know if their employees can tolerate the cold better than others. Okay, so what exactly is happening when it's frozen? Now, this is our best understanding thus far, and certainly work needs to be done on this. And so early on, it can be difficult to tell, even before the patient is thawed out, whether they have frostbite or at risk or not. So the history is important. Have they had significant exposure to the cold? Their digits can look pale, they can look waxy or blue, they don't get red and beefy and blisters until after they've been rewarmed, and things like eschar and necrosis take a few days to develop. Now, this can be very challenging, and I still find it challenging to this day after having seen dozens of frostbite cases. And so this is a patient, you can tell their fingers look a little bit dusky. They've been warmed up now. We've done our rapid rewarming. This is the first day. You wonder if they have fingers that are involved, but it doesn't really look like it's involving the palm. 24 hours later, their entire palm has blown up into a blister, particularly on the right, pretty significant on the left. And then even more concerning that it all looks worse 48 hours later. And what this is telling us is that if we're going to intervene, likely the sooner the better. If you're waiting for 48 hours before deciding this patient has significant frostbite injury, potentially you've missed your window. So what is going on? What is the pathophysiology of frostbite? Well, first, there's a freezing injury, which predominantly, most of these cases are a cold progressive injury. So this isn't flash freezing where you potentially have stuck your hand in a vat of liquid nitrogen. And what occurs is extracellular ice crystal formation starts, and it begins to create osmotic changes and fluid shifts, some early endothelial damage to the subdermal plexus blood vessels. Pretty significant injury that potentially is causing irreversible damage, where we want to intervene, is the thaw injury, the reperfusion injury. And this is highlighted by vasoconstriction, again, secondarily, not getting blood flow to the extremities, and thrombosis, clotting of the small vessels, which again causes it difficult for blood flow to get in and potentially get out. And eventually tissue breakdown, blister formation. And we'll talk Josianne will talk a little bit more detail in what has been discovered in some of these blisters and how this directs some of the care. So this is really the injury that we are trying to treat with our pharmacological interventions. It's this reperfusion post-thaw injury. Now, I spoke earlier about the sooner the better. There is some data. This is out of Minnesota, which is one of the larger US centers that sees a lot of frostbite and does great frostbite research and tracks their data. And they have shown that for every hour that passes after that patient is rewarmed, there's a 28% decrease in salvage rate. In other words, there is an increased risk of amputation for every hour that passes after they've been rewarmed. So this is raising the topic of what we call warm ischemia time. So they're rewarmed now, they're having their reperfusion injury. The sooner you intervene, the better. So really, to understand who we decide to intervene on, we need to discuss a little bit about grading, and I'll try and hopefully make this as clear as I can. So you may have heard of degree. So people will borrow the degree terms from burn injuries, which aren't entirely accurate. The frostbite injury we're talking about is a progressive injury, distally working proximally as you get frozen. Degree is really depth into the tissues. While useful, it's really not prognostic, because this could be a very small area, for instance, that's not even on the periphery. And so you're not necessarily describing this injury that's talking about the risk of amputation to fingers and toes. When you're talking about the depth of injury, what is more useful likely is it superficial or is it deep? And the easiest way to decide if it's superficial or deep, once they're rewarmed, is usually blister formation. If they have hemorrhagic blisters, that's deep to the dermal plexus, and that's telling you that it's a deep injury. What is more useful for frostbite is grading, and this comes out of work done in France and Chamonix. And so what they did is they did a retrospective analysis of all the frostbite cases that they had. Now, there are patients that had bone scans within 48 hours of their injuries, so nuclear medicine test, looking at perfusion. And so if you look at the picture of this on the left here, these dots are placed on the fingers to represent where the fingers actually are. All of this dark area is perfusion, and this blank area here is areas of the fingers that are not perfused, because the dots are telling you where the ends of the fingers are. Then they looked at these cases and tried to find if they knew what their amputation level was. So this is that patient on the right. You can see that this is an X-ray after they've had amputations, and their amputation levels are pretty close to what they showed on the bone scan. So in other words, can we predict from a bone scan what their ultimate amputation level was? Using this data, they developed a grading scheme, which is trying to tell people what somebody's risk of amputation is after you've looked at their rewarmed tissue. And can we do this clinically without even a bone scan, which is our area of interest? And so they developed this grading scale, which is what we use. And really what this is grade 1 means no cyanotic changes, no hemorrhagic blisters. And cyanotic changes usually look blue or dusky. Grade 2 is cyanosis of the distal phalanx, no hemorrhagic blisters or not significantly so. And the amputation rate of that is quite low. It's probably in the single digits. These are our best guess for the amputation rate with no treatment. Grade 3 starts to become a significant injury. Cyanosis into the middle or proximal phalanx, but not into the hand itself or not into the foot. And that amputation rate, depending on fingers or toes, appears to vary, but it's at its lowest end, it's still quite significant at least 40% and as high as 80%. Once you're into the metacarpals or metatarsals on the feet, the amputation rate without any clear intervention is nearly 100%. Now, that doesn't mean the amputation is right where you've seen the changes. It's going to be the risk is amputation somewhere, and we're trying to mitigate that, either make the amputation less or not have to amputate at all. So this is really important to understand if you want to understand how we're treating these frostbites, is the grading system from 1 to 4. And what it means in practical terms is as the cyanosis moves proximally on the digit, your risk of amputation increases. And so looking at this in graphic form, the same data, you can see that on this scale, on the y-axis is risk of amputation. As you move proximally, so in other words, from the fingertips to the hand, your risk goes up. And those are the curves that we're trying to influence. For research purposes, there's similar to the rules of 9 in burn, there is a Hennepin classification that gives a number that we are probably going to explore a little bit. We don't currently use this in great detail at this point. There isn't great imaging right now that's going to tell you at the time other than a bone scan. And if you, like us, don't have access to a bone scanner, then that's problematic. We've experimented a little bit with fluorescence, which is something potentially that's easier to use, but it is equipment investment intensive. But there isn't good early imaging in most areas that is useful for frostbite. It's more of a clinical diagnosis at this point. So the principles of treatment, some of these are historic, certainly from Mills's work in Alaska in the 60s. Rapid rewarming in water seems to be the best
a great talk on the
rewarming.
Whitehorse protocols.
And certainly early movement wound care we have as part of our protocol. We do hydrotherapy, which appears to give some relief, help them with their range of motion. And Josianne is going to talk about our advanced therapeutics, and we try and avoid surgery until such time that we feel that that inevitably is needed. The other important issue is refreezing is a disaster. So once they've rewarmed, you need to keep them warm. If they get a secondary early injury, they get much more significant tissue damage that can be much harder for us to impact. We have a rewarming tub, which works well for us. It doesn't have a heating element. It's just well insulated, circulates it, and we tend to do it anywhere between 37 to 39 degrees. If you can't measure the temperature, something that your hand could tolerate for 30 seconds would likely be warm enough, but not too warm. So just in review, we're going to move on to how we treat these with our aggressive treatment. Josianne is going to talk about this in some detail. And just to remind you that what we're talking about mostly is treatment of the rewarming injury, and vasoconstriction and thrombosis are the enemy in this scenario. And I will let you, Josianne, if you want to share your screen and carry on.
Hey, thanks, Alex. Everybody can see my slide here?
Yep.
Okay, great. So I'll do a bit of a deeper dive in frostbite treatment and review the different treatment options. So first, to understand treatment, we have to understand what happens in frostbite blisters after rewarming. So this is the arachidonic acid pathway. There was some interesting research that was done in the 1980s where they aspirated the fluid from frostbite blisters. And what they found was that in frostbite blisters, there were elevated amounts of thromboxane B2 and prostaglandin PGF2 alpha. So these are bad prostaglandins that are responsible for vasoconstriction and platelet aggregation. They also found that there were low levels of the good prostaglandin PGE2, which is a substance that has vasodilating properties. So this led to early studies in frostbite treatment using aloe vera and aspirin. So the plant aloe vera has substance that inhibit thromboxane B2 and limits the production of prostaglandin PGF2 alpha. In animal studies with burns, aloe vera improved reperfusion after treatment. So they went on to study that in animals with frostbite, and aloe vera did improve tissue survival. And then they did some studies in the States in the 80s in humans, like in patients with frostbite. And when aloe vera was incorporated to a frostbite protocol with other modalities of treatment, tissue survival was better. There was less amputation compared to their standard of care. The cream that they use in the state is a Dermade aloe, and this cream was actually developed by the burn surgeons that studied frostbite and burns in the 80s. It's a cream that has a high percentage of aloe vera, but unfortunately, this is not available in Canada. So what we have been using is an aloe vesta ointment. which is aloe vera in a Vaseline base. However, it has a low concentration of aloe vera, and it was just discontinued from the market. So we're currently looking for an alternative. I don't have a specific product to recommend other than avoiding any product like after sun product that may have lidocaine or anesthetic agents or alcohol, because that makes the product those products can be very sticky and be challenging for wound care. NSAIDs block the arachidonic acid pathway. Logically, pharmacologically speaking, they can be useful in frostbite. First, aspirin was studied in animals with frostbite, and it improved tissue survival. And in human studies, aspirin decreased the rate of amputation compared to other methods of treatment. The use of ibuprofen specifically was popularized by Hagers and his colleagues in the 80s. And they said back then that ibuprofen was more active against thromboxane and that aspirin should not be used because it impairs with the production of the good prostaglandin. However, this was never verified, and we still incorporate NSAIDs and often ibuprofen in our frostbite protocol. Most centers do include ibuprofen to their frostbite protocol, both for its pharmacologic action, but also for pain management. The first treatment that really addressed the thrombosis that happens after rewarming were tissue plasminogen activators. They break clots in the extremities and help restore the blood flow to prevent ischemia. As you know, the most significant risk with thrombolytics is the risk of bleeding, and it can be serious. So for that reason, many centers, many hospitals have a list of contraindications, and it's usually given in the ICU. In a recent study that was published in Minnesota, they looked at their rate of complication with alteplase in frostbite patients, and 8% of their patients treated for frostbite with alteplase had bleeding requiring intervention. Several thrombolytics were used over the years, but the one that is most commonly used right now is alteplase. It was first used in the 90s in the States, but the first publication on its use in frostbite came in 2005 and by the researchers from Minnesota. Since then, there've been over 15 publications totaling over 300 patients. Most were case reports, case series. Only a few were controlled and all retrospective, except for one prospective randomized control trial. In most of those studies, patients with frostbite were assessed by either angiography or bone scan right after rewarming. And in those patients with decreased perfusion, where amputation was likely, alteplase generally was effective at restoring the perfusion to at least some degree and decrease the rate of amputation. In early studies, alteplase was given intra-arterially by a catheter-directed intra-arterial infusion, like with the help of a radiologist. That was definitely a barrier to using thrombolytics in frostbite, especially in smaller hospitals or remote locations like us. But in most recent years, alteplase has been given with success intravenously for frostbite. A good systematic review compared the efficacy and rate of complication with both routes of administration and found that regardless of how it was administered, it was effective at reducing amputation rate, and the complication rate was similar. Factors that are associated with treatment failure with thrombolytics is delayed presentation, multiple freeze-thaw cycle, and delay in thrombolytic initiation. So time from rewarming to alteplase has significant impact on amputation, and the sooner it can be started, the better, ideally within 4 hours after rewarming, up to 12 hours. Heparin is generally given during or after thrombolytic, and that's because the fibrinolysis that occurs has procoagulant effect by clot extension and reformation. In Whitehorse, we use enoxaparin because it's more convenient. It can be given subcutaneously as opposed to an infusion, like a heparin infusion. And most centers experienced in treating frostbite are now using enoxaparin as well. Other anticoagulants and antiplatelets have been used, but of course there's some challenges and barriers with that if it's prescribed on discharge, and I would say that it's not very consistent what centers do after discharge. Iloprost has been key for the treatment of our patients. So iloprost is a drug, intravenous drug that was developed in Germany in the 1980s. It's been used intravenously for Raynaud disease, for peripheral arterial disease, chronic critical leg ischemia, systemic sclerosis. It's a potent vasodilator, which addresses that vasoconstriction that happens after rewarming. Vasodilators can also help improve thrombolytics efficacy by improving the access of the thrombolytic drug to the extremities. Iloprost is not only a vasodilator, it inhibits platelet aggregation, and it may even have some fibrinolytic properties. The most common side effects with iloprost are headache and flushing, and they're dose related. And it can be generally avoided by titrating the infusion rate slowly, titrating up the rate progressively. And usually the side effects subside quickly after discontinuation. So to understand how iloprost works, we go back to that arachidonic acid pathway. Prostaglandin PGI2, or also called prostacyclin, is an endogenous potent inhibitor of platelet aggregation and a vasodilator. And iloprost is a synthetic analog of the indigenous prostacyclin. Alex and I did a scoping review of the literature, which was published earlier this year. So we scoped the literature for any publication on the use of iloprost for frostbite, not limited by language of publication. And we analyzed 20 studies published from 1994 to 2022. The majority of publications were case reports, followed by case series, one prospective single-arm study, and one randomized control trial. All the publications totaled 254 patients treated with iloprost for frostbite, including over 1,000 frostbitten digits. The majority of patients in studies were males in their 40s, and sport was the leading cause of frostbite, present as the predisposing event leading to frostbite in 15 out of 20 of the studies that we found. The first published report of iloprost use in frostbite came from Austria. So an Austrian physician treated frostbite patients with iloprost, and all patients had full recovery. In 2011, Dr. Cauchy in Chamonix, France, published the only prospective randomized controlled trial on the treatment of frostbite. Alex and I published our case report describing our first two patients in 2016, and later published our 5-year experience in 2021. And last year, a team from Calgary also published their experience. So there's no studies from the United States, and that's because iloprost is currently not commercialized in the United States and only available in Canada through the Health Canada Special Access Program since 2015. So even though the evidence comes from retrospective case reports and case series, the literature does suggest that iloprost reduce amputation rates in patients with frostbite. Some of the strongest evidence comes from Cauchy in Chamonix in that randomized control trial, where there was no amputation in the iloprost group. And also the study from the Calgary team published last year found that their amputation rate was significantly reduced amongst patients treated with iloprost compared to historical patients or standard of care. Amputation was reduced by more than 50% in both grade 3 and grade 4 frostbite patients. We still don't have any studies comparing iloprost to alteplase, but in a study from Finland, they used iloprost if there was a contraindication to thrombolysis or if patients had no response or failed to respond to thrombolytics. And what they found is iloprost may be effective in patients that have no response to thrombolytics. A big advantage also of iloprost is it seems to maintain its efficacy longer after rewarming. So in studies, iloprost maintains its efficacy up to 72 hours after injury and possibly longer. So now just speaking to wound care a little bit, most of the research that we have on frostbite wound care goes back to work from Dr. Mills in Alaska in the 1960s. What they did back then is compared an open method or open dressing to closed dressing. The open method was absolutely no dressing, nothing on frostbite. And in their closed method group, they used occlusive dressing, ointments, and even plaster. And what they found is in the closed method group, there was more amputation, probably explained by high risk of infection. And these studies still dictate what our wound care approach today. So we use non-adherent dressing, gauzes for padding, and bandages rolls to keep it all together. So as of topical treatments or ointments and creams, antiseptic solutions have been used since the 60s, and they're added to the rewarming water. And we do add a small amount of antiseptic to our rewarming water. There are some anecdotal reports of use of flamazine in frostbite, but even in the treatment of burns, its efficacy is controversial, and there are some concerns that it may have some cytotoxic effect and may delay healing. So I do not recommend using that. And as for antimicrobial ointments like polysporin or so on, they're probably not necessary because frostbite wounds generally don't get infected. So really the only tropical product that does have evidence in frostbite is aloe vera, or the first product that was actually studied. So Alex and I developed our frostbite protocol back in 2015. We developed an algorithm and order sets to streamline frostbite treatment at our hospital. The first steps include rapid rewarming in hot water, and then that visual grading of severity using the Cauchy classification. And in all patients, grade 1 to 4, we do daily hydrotherapy. We apply aloe vera and give ibuprofen. We treat grade 2 to 4 with iloprost, which is given as an intravenous infusion for 6 hours on a daily for 5 days if patients present to the hospital 72 hours after rewarming. Iloprost is distributed in the tissue quickly. It's like in about 4 minutes. It's eliminated within 30 minutes, and its effect on platelet aggregation is quickly reversible. But studies in patients with chronic ischemia has shown that even intermittent infusion of iloprost has long-lasting effects. So we give iloprost grade 2 to 4, and in those patients with grade 4 frostbite, we also give alteplase in addition to iloprost if the patients present to the hospital less than 24 hours after rewarming. So these were the pre-printed orders that we initially developed. Now we have an electronic medical record system, so they were converted into electronic order sets. the first barrier that we had to overcome when we developed our protocol was actually accessing iloprost in Canada. As I said, it's not commercially available yet, but is accessible through Health Canada's special access program. So physicians just have to request authorization for future use. So iloprost can be stocked in hospitals ahead of time before frostbite patients present. So I'll speak a little bit to our experience so far. So we've been using our protocol for almost 9 years now. We published our experience with the first 5 years of our protocol from 2015 to 2020. In that series of cases, we treated 22 patients with severe frostbite graded from grade 2 to 4. They all received iloprost, and 5 patients also received alteplase, so grade 4 patients. The majority of our patients were male, in 77%, and 39-year-old in average. As Alex mentioned, most of our patients had frostbites at temperatures colder than -21 degrees Celsius, and most cases occurred between -21 and -30 degrees Celsius. 45% of our patients got frostbite from a sport activity, the majority participating in that Yukon Arctic Ultra, that running race that takes place every year in February. And about 30% of our cases were related to alcohol and substance use, which showed a trend towards more severe injury. Iloprost was very well tolerated, with headache being the most common side effect. One patient on iloprost had bleeding, but had a recent altercation and was receiving anticoagulation. And another patient on iloprost did develop a perforated duodenal ulcer. However, he was receiving scheduled ibuprofen without gastric protecting agent. So since then, we've added a PPI to our protocol. 2 of the 5 patients receiving alteplase did get bleeding complications requiring blood transfusion. There were a total of 142 digits affected in our series from grade 2 to 4. We had 0 amputation rate in our grade 2 and grade 3 frostbite. And in our grade 4 patients with frostbite grade 4, where the amputation risk can be as high as 100%, our amputation rate was 50%. A result that was impressive is since the implementation of our protocol, we reduced the time from presentation to treatment significantly. And we know that this is critical for the drugs to be effective and to reduce that warm ischemia time. And I think that having a protocol, having order set really helped. We also offered education to our hospital staff, but also the community health centers across the territory. So yeah, I think even in Whitehorse, where we don't get that many cases of frostbite a year, having a protocol in place really helps streamline management. So in terms of future directions, the more we study frostbite, the more we have questions. There's still a lot of research questions that remain. Like it would be great to have data on alteplase versus iloprost. Is combining both more effective? What is the best adjuvant treatment? What is the best topical treatment? So there's definitely more research questions that remain. We actually have put together a little team of general surgeon, burn surgeon, pharmacist, medical student, residents, and researchers from across the country to create a little Canadian frostbite collaborative. And we are conducting research on frostbite care in Canada. As Alex mentioned, we're currently working on an epidemiology study on using Ontario database. And we just published a qualitative study in July. And in that qualitative qualitative study. We surveyed healthcare providers across the country and did some focus group to look at how we could improve frostbite care in Canada. And what came up is the need to create or to develop a Canadian frostbite care network. And we are in the early stages of setting this up. And our goal is to facilitate research, educate stakeholders, both public and healthcare providers, and encourage collaboration. We hope that creating that network will help modernize frostbite care in Canada. That is all for our presentation. We welcome your questions. I'll stop sharing.
Okay, thank you, Josianne, Dr. Poole, for that fantastic, informative presentation you've just given us. I really do appreciate it. Just for our group, if I might just take about 5 minutes or so just to go over our protocol that we will be rolling out. And I have to say, disclaimer, I don't know much about frostbite, so and frostbite care. So I really appreciate all the information that UConn team has provided to us and their kindness to share their protocol that they had developed and allowing us to adapt a lot of their work here that's reflected in the FNIB Ontario region frostbite care that our protocol that we're going to be rolling out. So I'm just going to share here our screen if I can, just to let you know that this will be coming out to us. And can you see my screen?
Not yet.
Okay. All right. Does that come up?
Yep, we're good now.
Okay, great. Thank you. So the first page, there are 8 pages to this protocol for our protocol. The first page is the usual that you would see with ensuring that you take the basic vital signs. If the physician or the prescriber is not on site, this is really important that nurses cannot initiate any treatments here without the consultation and the verbal orders from the prescriber. If the physician or nurse practitioner might be on site, then it would be best that they are given this protocol and have it filled out so that the initiation of treatments can be started. So usual diagnostic tests for this in particular, as Dr. Poole had already alluded to in his presentation, there really aren't real good diagnostic tests, thankfully, for this condition. The second page is the lab, just in case there's some lab that is required to be ordered. But this is the important piece, the medical evacuation. We don't have, as Josianne had mentioned in her presentation, that some of the pharmacological interventions at the nursing stations. So iloprost, keep that in mind. I mean, the earlier we can get this into the patient with, even grade 2 up to grade 4, the earlier intervention we can get into them, that possibly means saving that limb. So we've put in here medical evacuation if for grade 2 to grade 4 frostbite. And if they have this concurrent hypothermia, if there's infection, we should all be thinking about it. Thunder Bay is the only center right now near our northwestern site that has iloprost. I've checked with Winnipeg, they don't have it. So anytime you have frostbite patients where you're considering a further treatment, Thunder Bay is our group to reach out to. The assessment piece, I won't go too much over it because it's well laid out in here with the information that you should check the patients on. But consider if they've had frostbite injuries, do the thorough examination, because as stated here, other sites could also be affected in areas that we may not even see, right? The buttocks, the perineum, even the penis, right? So think about these areas that we don't usually see when up front. look and note, and here some of the check boxes for areas that you're examining, but refer to page 10. It's the second last page of the protocol, and circle the areas in your examinations. You know exactly what areas are affected, and it's easier to follow up when the following days that are with other clinicians that may be involved in the assessment. The Koshi system is put in here so that you can quickly refer to the different grading. The important piece here is about rewarming the frostbite areas before the examination happens. So, make sure there's a follow-up, because as the picture Dr. Poole had shown, day one may look like there's nothing happening, but then things start to blow up. So make sure there's that follow-up of the patient, so that they can get the further intervention as necessary. Just here's some of the pharmacological information that's required. So the rewarming process is all laid out in here. I just want to highlight to you here, I'm going to change it slightly under the procedure. We're going to put the stanhexidine solution in here rather than just the chlorhexidine gluconate 4% in here. I use this based on the ICU decolonization, decontamination processes that they usually do, but the stanhexidine, as I discovered, also has a bit of isopropyl alcohol in it. So it's nice to have that broader coverage for decontamination. So that's the only change I will update in our protocol. And then wound care, right? It's the whole list here of what needs to be done to help that, to save that limb possibly. So as much as we can to standardize that wound care, everything's laid out there. In terms of blisters, it's, when you're looking at blisters, don't break them unless they interfere with joint movements. Don't debride them. And if you do, make sure there is that consultation with the surgical team that we might be transferring these patients to. And then some of the counseling aspects for patients are all laid out here. Make sure that they avoid tobacco, alcohol if possible, and paying attention to how our dress is important, because as stated earlier in the presentation, you don't want to have that freeze thaw and freeze process. It actually worsens the condition. And then under pharmacological intervention here, tetanus, always check about their tetanus status to give them the updated injection as required. And then when it comes to pharmacological intervention here, we've got mild to moderate, but the aloe vera is where we are going to implement in all the nursing station. The ibuprofen, again, if it is to be started to minimize or to control that inflammatory process that's happening, it's to be given straight. It's not a PRN. I thought it was a PRN thing, but Josianne really helped me understand the essential or the critical path as to why it cannot be PRN. It has to be scheduled to control the inflammation. And for those patients with high risk of GI bleed, you're thinking of patients with alcoholism, anybody who's over 64 years old, diabetes, you had a history of GERD, or they're on other antiplatelets or anticoagulation, but the benefit of adding ibuprofen for these patients would be better for them to control that inflammation. Then make sure you give them some cytoprotection. And what we do have is rabeprazole here. So if that ibuprofen's checked off, they're high risk of GI bleed, rabeprazole should be added to the treatment. And then lastly, for severe pain management, there's opioid options here to consider for those patients. And then all the monitoring and follow-up parameters for those patients. And last bit here is just the protocol, sort of a summary protocol we have at the end of this. So with that, I just want to have a quick thank you. This is put together by mostly Laura McCluskey, who was our pharmacist here last year, and she's just off on mat leave now. And Marie-Hélène, thank you if you're on, because she helped us to align it with the national clinical care protocol as much as she could, so that we align in terms of management. So thank you everybody for all the work that has been put together for this protocol. That's it for my bit.
Thank you all so much. I see a couple questions in the chat. Thank you, Josianne, for fielding half of them. There's a question about dietary modifications, if that's been explored.
Hi, it's Alex. That's an interesting question. The short answer probably is no, we haven't come across that in the literature. It's really difficult to sort out, I think, areas that are used to the cold and potentially have a low rate of frostbite, whether there's a predisposition to, or at least they're cold protected physiologically or from behavior, which is going to be difficult to sort out. And I think part of the behavior part may be what nutrition that they're taking. I know with the cold induced vasodilation I was talking about, there's been some attempts to see if there are ethnic groups that have an enhanced response versus others. And so far, that doesn't clearly seem to be the case.
Thank you. Ha, I think this next one's for you. Just to clarify that aloe vera and the solution for rewarming, probably the antiseptic solution to be added to rewarming water is going to be added to the formulary. Do we have dates on that yet?
Yes, thank you for that question. Yes, we're hoping to roll all of this out at the last week of September and the first week of October. That's our plan. We're ordering them in, or they have been ordered in, but we're hoping to roll all of this out, the aloe vera as well as the stanhexidine solution, and we're hoping to tag it on with Tamiflu as well, since our flu season is here, so that you, as nurses, you don't have to order any of these products. We will pre-package them, and they're all going to be sent up together.
Perfect, thank you.
Thank you.
There's another question on when is the most accurate time to grade the frostbite?
So this is an excellent question. Probably the most accurate is 72 hours, which unfortunately is too late for an intervention, ideally. And this is entirely why we started treating grade 2s. Does grade 2 frostbite really need to be treated aggressively with iloprost, for instance? Maybe not. However, my concern is, based on that slide that I showed you, and I've seen this in numerous patients now, that it can be very difficult at the beginning to tell if it's grade 2 or grade 3, and as the amputation rate really starts to climb. And so you have a pretty good guess right away when they're rewarmed, but it can look worse, and that's your clinical diagnosis, will increase over the 24 or 48 hours. And so you want to treat them as soon as possible. And so that's an excellent question. That's something we would like to understand better. If you did a bone scan, for instance, right away, it likely would be more accurate, and maybe with fluorescence as well. But that speaks to the difficulty of early on knowing how bad it is. So we err on that it's going to get worse in the next 48 hours, and we should treat them aggressively if they're on the border of needing treatment.
Thank you. Any more questions from you guys out there?
I have a question for Josianne, actually. I kept wanting to ask, and I keep forgetting. In your experience with ibuprofen, I know it's one of the more potent anti-inflammatory for what you have seen, but for patients with higher risk of higher cardiovascular risks, do you guys use naproxen or something that has a lesser effect of it, but still get that anti-inflammatory effect that we want?
No, like we use ibuprofen. Like in Finland, they use in some centers they use baby aspirin just to direct at the anti-thromboxane effect. But again, we're using a more broader NSAID for that protection of the good prostaglandin. So we kind of base ourselves on what data is available so far. So that's what we've been using.
Okay, thank you.
I can handle the blister question. So the question is, just to clarify, I'm not sure I'm going to clarify, should we aspirate blisters or leave them alone? This is a great question. So the short answer is all the big blisters will eventually fall apart at some point. I would hesitate to do anything with hemorrhagic or bloody blisters, which is a deeper injury, unless you absolutely have to. And usually that means that it's impeding their motion, it's going across joint surfaces, that sort of thing. I do aspirate all of the clear blisters of any significant size for two reasons. One, they're all going to fall apart eventually and become a wound care problem. Or the other reason that I do it is, in theory, because they do contain those bad thromboxanes, which they found in the 80s when they aspirated them and analyzed them in Chicago. So I aspirate and probably early debride any significant clear blisters. I leave hemorrhagic blisters alone if I can.
Thank you. Liz, I saw your hand was up. Did that answer your question?
No, I was wondering, yeah, because the blister will just saturate the dressings, right? But the for the rewarming, so if someone comes in with these like cool waxy digits, and we don't have that fancy water bath, so we've got sinks and tubs, is that what we'd be using?
Yeah, for sure. I mean, the funny story for us is that oh, somebody needs to be mute because we're echoing. When we first looked at all the literature, we found that most people were rewarming somewhere between, I think it was 36 and 40 degrees. So logically, I picked 38 for our protocol. And then the very first time we were rewarming somebody in our trauma bay, I looked over and the nurse I was working with was pouring a jug of cold water into our bath. And I said, well, what are you doing? She says, well, it's 39 degrees. I'm trying to cool it to 38. I'm like, so it comes out of our tap at 39? And she said, yes. And I said, well, we're changing the protocol to 39 then, because this is crazy, because there's no evidence that it's any different. So absolutely, any warm water is fine. About the temperature of a hot tub or what would be maybe a warm bath that you would tolerate. There's no magic to the number, and most people use as a guess. If you can put your hand in it and tolerate it for 30 seconds, then that's probably not too hot. And as hot as you can get up to that is probably fine. People haven't really analyzed the difference between, say, 32, 34, 36, or even 40 degrees, but most people use something between 36 and 40. So you don't need anything fancy, but you do have to be careful there isn't a heating element in it, because if these people are relatively numb, they could burn their hands or their feet if they're on the hot area.
And does it need to be moving water, or can it just be still?
I mean, moving is more efficient because you don't you get more of the convection heat exchange, but does it have to be? No.
Grading based on appearance, wondering if factors such as active alcohol use or tobacco use would be a modifier in terms of triaging the urgency of the cases.
Likely. I mean, that their prognosis is probably worse if they have other reasons that they have poor circulation, but we haven't sorted that out through the data at this point.
Okay, perfect. Thank you both so much. This is amazing. And like Ron said, this is perfect timing just as we're getting into our very cold season. I'm going to wrap for now just because we are about 5 minutes over. So thank you all. I'm just going to hit stop recording.